Hello, viewers. Good day to all of you. So, this is Dr. BK for you again with today's lecture on the upper limb. So, in today's lecture, I am going to talk on two joints. One is the wrist joint, and the second one is the first Carpometacarpal joint. So, with regard to these two joints, I will be discussing under the following headings. So, mainly as any joint, we will be starting with what type of joint it is and which bony surfaces, articulating surface, take part in the formation of the joint. So, supports of these joints being the ligaments, then followed by the relations, then what are all the movements which are possible in these joints, muscles which are going to produce these movements, and finally we are going to see the nerve supply, arterial supply, and few aspects of the applied anatomy with respect to these two joints. So, to start with, we are first dealing with the wrist joint. So, here you are able to see the wrist joint. It is actually a synovial joint, ellipsoid variety. So, biaxial. So, the ellipsoid variety is mainly based upon the shape of the articulating surface. So, it is somewhat elliptical in nature. Superior articulating surface which is concave from side to side, whereas the inferior articulating surface is convex. It is a biaxial variety, which means movements are possible around two planes. So, one is flexion and extension in one plane, adduction and abduction in another plane. So, a combination of these movements will produce circumduction. So, that is called as conjunct rotation. So, what will be the articulating surfaces? The superior or proximal articulating surface is formed by the inferior surface of the radius. Okay, the inferior surface of the radius and the lower surface of the triangular articular disc. So, the articular disc has got an apex and a base through which is attached to the radius, and on the groove between the lower end, that is the head of the ulna, and the styloid process of the ulna. Okay. So, the shape is elliptical, and here it is important to note that the lower end or the head of the ulna is non-articular, does not take part in the articulation of the wrist joint. Instead, it is the intra-articular disc. Okay. So, the wrist joint has got a separate cavity lined by the synovial membrane. This is separate from the cavity of the inferior radio-ulnar joint. Okay. So, the inferior radio-ulnar joint cavity is actually separate from the joint cavity of the wrist joint. The lower articulating surfaces are mainly formed by the superior surface of scaphoid, lunate and tricutral. So, the upper surface, which is again elliptical from above or convex from side to side. So, that is about the superior or the proximal, and then the inferior or the distal articulating surface. So, upper part it is formed by the lower surface of the radius and the inferior surface of the triangular disc. Now, coming to the ligaments, it has got a capsule which invests the joint, the articulating surfaces is covered by it. Then the ligaments are the palmar radiocarpal and the dorsal radiocarpal ligaments. So on the radial aspect, you have on the palmar and dorsal side, palmar and dorsal radiocarpal ligaments. You also have more laterally the radial collateral ligament. Then you have the ulnar carpal ligament. Then you have the ulnar collateral ligament. Okay. So ulnar collateral and ulnar carpal ligament is also present. So we are going to see these ligaments one by one. So first one being the capsular ligament. It is attached to the margins or periphery of the articulating surfaces, including the articular disc. So along the margins of the inferior surface of the radius and the articular disc, and along the margins of the scaphoid, lunate and the triquetral. In the front, the capsule blends with the radiocarpal ligaments. The head of the ulna does not take part in the articulating process. Okay, the head of the ulna is excluded. So it is lined by synovial membrane, and as I told you, this joint cavity which is lined by synovial membrane is actually separate from the inferior radioulnar joint cavity. Coming to the ligaments, palmar radiocarpal ligament. So here you are able to see the palmar radiocarpal ligament, which is somewhat extensive and a thick band from the lower surface of the anterior part of the lower end of the radius. It runs somewhat medially downwards to the palmar aspect of the scaphoid, lunate and triquetral, all the three bones. That is about the palmar radiocarpal ligament. Okay, so on the palmar aspect means it is present on the anterior part of the lower part of the radius and goes to the palmar aspect of scaphoid, lunate and triquetral. The next, behind you come across one more ligament, that is the dorsal radiocarpal ligament. So that is the dorsal radiocarpal ligament. Same way like the palmar carpal ligament, this arises from the dorsal aspect of the lower part of the radius, runs obliquely to the dorsal surface of the scaphoid, lunate and triquetral bones. Okay. So you have one is the palmar radiocarpal ligament and other one is the dorsal radiocarpal ligament. Coming to the ulnar carpal ligament, again on the palmar aspect, what you see is the palmar ulnar carpal ligament. From the anterior surface of the lower end of ulna, it goes mainly to the lunate and triquetral bones. Okay, to the proximal row of the carpal bones, mainly the lunate and the triquetral bones. You also have the radial collateral ligament from the styloid process of the radius to the scaphoid and trapezium. Okay, so radial collateral or lateral collateral ligament. So we have seen so far 4 ligaments: palmar carpal ligament, dorsal carpal ligament, palmar ulnar carpal ligament, and the radial or lateral collateral ligaments. The next ligament is going to be the ulnar or medial collateral ligament from the styloid process of ulna, and it goes to the triquetrum and the pisiform bone. Okay, radial carpal ligament is attached to the scaphoid and trapezium from the styloid process. The ulnar carpal ligament extends from the styloid process of ulna to the triquetral and pisiform bone. So these are the ligaments. So right from the capsule, then you have the carpal, palmar carpal and dorsal radial carpal, then palmar ulnar carpal, then you have the 2 collateral ligaments, that is ulnar collateral and the radial collateral. These two are actually present at the sides, same like your collateral ligaments of the elbow joint. Now coming to the relations of the wrist joint, laterally it will be related to the anatomical snuff box. So there is abductor pollicis longus, extensor pollicis brevis and extensor pollicis longus, and radial artery running between these tendons, which is a content of the anatomical snuff box. Medially, you see the dorsal interosseous and not the dorsal interosseous, the dorsal cutaneous branch of the ulnar nerve. You see here. Anteriorly, you see the flexor tendons of flexor pollicis longus laterally and flexor digitorum profundus medially, deep flexors. So, the flexors, deep group of flexors, and along with them is the median nerve. So, you see the median nerve, then you have the ulnar artery and the ulnar nerve which is lying medially. So, they all form the anterior relations for the wrist joint. Posteriorly, you have the extensors running. So, that 6 compartments we have seen, the extensor retinaculum dividing into 6 compartments. So, abductor pollicis longus and extensor pollicis brevis, extensor carpi radialis longus and brevis. Then you also have the extensor digitorum with the posterior interosseous nerve, artery and all those things. Then you have the extensor indicis, then extensor carpi ulnaris running in each compartment, except the supinator unconeus, which actually is present more proximally. They don't reach, they are not long flexor extensor tendons. Abductor pollicis longus and extensor pollicis brevis, actually they have an oblique course. So, apart from that, all the other extensor tendons forms the relations. So, the relations anteriorly flexors, you see the deep flexors with the median nerve, radial ulnar nerve and ulnar artery. The movements of the wrist joint. Now, coming to the movements of the wrist joint, it is associated with the mid-carpal joint. So, that means movements takes place at the wrist, that is between the what you call the lower end of the radius and the triangular disc and the proximal row. So, that we call it as the wrist joint. Then between the proximal row and the distal row of bones, you also have some joints which also permit some movements of the wrist. This is also called as the link joint. So, it is linking your inferior radio ulnar and the mid carpal joints. The movements possible around this joint are the flexion, extension, adduction, abduction. So, it is a combination of conjunct rotation takes place, that is the above movements will produce conjunct rotation. There is no axial rotation, which means there is no separate rotation, there is no separate axis around which rotation takes place. So, that is why. Now, when you look at the movements of the wrist joint, mainly you are able to see this is the flexion and that is the extension. Flexion and extension takes place around a transverse axis. Okay. So, you take a transverse axis and around the axis what you see is the flexion and the extension. Now, flexion takes place at the mid carpal joint, whereas extension takes place at the wrist joint. That is one thing. Second thing is, so more at mid carpal joint. Second thing is, when your digits are flexed, then the range of flexion is also diminished. Okay, when you flex your digits and then you try to flex the wrist, there will not be very much efficiently you will be able to flex the wrist. Rather than you extend all your digits and try to flex, it is performed. So, the degree of flexion and extension is around 85 degrees, of which extension is more compared to the flexion. Now, because of this only, the posterior surface of scaphoid, lunate and triquetral are extensive. It has a more extensive surface for articulation than compared to the anterior surface. So, extension is more as compared to the flexion, and it takes place around the transverse axis, and the range of flexion and extension is around 85 degrees. The second movement what you see is adduction and abduction, which takes place around the antero-posterior axis. So the antero-posterior axis, and the axis for the adduction and abduction passes through the capitate bone. Okay, so the middle of the capitate. Then if you look at adduction and again abduction, adduction is more extensive as compared to the abduction. Now why? This is because what happens is the styloid process of ulna is very short as compared to the styloid process of radius. So due to the shorter ulnar styloid process, you can adduct more, which is around 45 degrees of adduction is possible, whereas abduction is very limited and accounts to around 15 degrees of abduction. So adduction definitely is more extensive as compared to the abduction. See, the degree angle of abduction is around 45 degrees as compared to the abduction. And abduction takes place again at the mid-carpal joint. So flexion, extension, adduction and abduction. So when you combine this flexion, extension, adduction and abduction in an orderly manner, what you get is the circumduction. Okay. So what is actually circumduction? Is adduction, flexion followed by abduction and extension. Okay. So these movements, when it is performed even in the reverse order, what you get is the circumduction. So circumduction is a combination of the flexion, extension, adduction and abduction. So what are the muscles producing these movements? Flexion of the wrist joint is mainly by the flexor carpi ulnaris and flexor carpi radialis. These flexor carpi ulnaris and flexor carpi radialis, which is assisted by the flexor digitorum superficialis profundus and flexor pollicis longus. Okay, so all the long flexors which are present mainly take part in the flexion of the wrist joint. Extension is by extensor carpi radialis longus brevis and extensor carpi ulnaris, which is assisted by extensor digitorum, extensor indicis and extensor pollicis longus. Adduction is by the combined action of flexor and extensor carpi ulnaris, both put together. Abduction is by abductor pollicis longus, extensor carpi radialis longus and brevis. So adduction is mainly by the combined action of flexor carpi ulnaris and extensor carpi ulnaris. Abduction is by abductor pollicis longus muscle, extensor pollicis, extensor carpi radialis longus and brevis along with extensor pollicis longus. Okay. So these are the movements and these are the muscles which are producing these movements, that is the flexion, extension, adduction and abduction. The nerve supply of the wrist joint is mainly by the anterior and posterior interosseous nerves, Hilton's law. So any nerve passing through the joint also supplies the joint muscles and the skin around the joint. Anterior interosseous nerve is a branch of the median nerve, deep branch of median nerve. Posterior interosseous nerve is actually a deep branch of the radial nerve. So the deep branch of radial nerve is actually called as the posterior interosseous nerve. Blood supply is mainly by the carpal arch, which is formed in front and behind the wrist joint. So anastomosis around the wrist joint is in the form of palmar and dorsal carpal arches. They are formed by the anterior and posterior interosseous artery. So the anterior and posterior interosseous artery, then on the palmar aspect by the palmar carpal branch of the radial and the ulnar artery, dorsal aspect it is formed by the dorsal carpal branch of the radius and ulnar artery, radial and ulnar artery. So palmar and dorsal carpal branches of radial and ulnar artery. Then recurrent branch from the deep palmar arch. Okay, so it is the recurrent branch from the deep palmar arch. So it is somewhat like a cross from above, below, and from the sides. It is formed in front and behind. So that is the formation of the carpal arch, which is responsible for the blood supply around the wrist joint. So here you are able to see the arteries, palmar carpal arch. So radial artery, ulnar artery will give a palmar carpal branch. Then anterior interosseous artery, after giving a branch, it will pierce the interosseous membrane and go posteriorly, taking part in the dorsal carpal arch. Deep palmar arch will again give a recurrent branch. So all this takes part in the anastomosis around the wrist joint. Now coming to the joints of the hand. So this is apart. So here we have seen about the wrist joint between the lower part of the radius, ulna, and the proximal row of carpal bones. Then mid carpal joints we have seen here, where some movements takes place in the mid carpal joint, flexion and abduction, whereas adduction and the extension is going to take place around the wrist joint here. Now between the dorsal or the distal row and the metacarpals, what you have is the metacarpophalangeal joints. So apart from the inter or mid carpal joints, what you see is the carpometacarpal joints. Okay. So intercarpal joints is between these bones transversely. Mid carpal is between the proximal and the distal row. Carpometacarpal is between the distal row of the carpal bones and the metacarpals. Then you have intermetacarpal joints. Then you have first carpometacarpal joint. Carpometacarpal joint of the thumb. This is somewhat different from the other carpometacarpal joints of the second, third, fourth, and fifth digits. So here when you look at it, the joints, carpometacarpal joints, are of plain variety. So they provide some gliding movements. So apart from the gliding movements, some very passive rotation takes place. Of these lateral medial four fingers, second, third, fourth, and fifth carpometacarpal joints, the fifth one has got more mobility as compared to the second, third, and fourth carpometacarpal joints. But the first carpometacarpal joint or the carpometacarpal joint of the thumb is totally different. It is a completely movable joint and it has got a wide range of movements. So that is why today we are going to see again extensively about this first carpometacarpal joint of the thumb. Then you have the interphalangeal joints, proximal and distal interphalangeal joints. Now coming to the carpometacarpal joint of the thumb, or first carpometacarpal joint, vice versa, however you want, you can call it as. It is a synovial joint and it is of saddle or cellar variety, which means reciprocally convexo-concave articulating surface. So you are able to see here actually it is side to side, it is concave, whereas here side to side it is convex. From front to back, anterior posteriorly it is convex, but here it is concave. So it is called as the cellar or saddle variety, reciprocally concavo-convex. This is one of the reason, the shape of the articulating surface, which promotes wide range of movement in the carpometacarpal joint of the thumb. This has got a separate joint cavity invested in a capsule, whereas the other joints, they are held together by the ligaments, mainly the carpal metacarpal ligaments, palmacarpal ligaments hold them in its place. But here you have a separate joint capsule and a separate synovial cavity. Interior is lined by synovial cavity. The articulating surface, this is the lower surface of the trapezium, the distal articular surface of the trapezium, which is going to articulate with the base of the first metacarpal bone. And the first metacarpal bone is the shortest and stoutest of when compared to other metacarpals. Okay. So that is the base of the first metacarpal bone. So as I told you, since it is a saddle variety, they are reciprocally concavo-convex or convexo-concave, however you want, you can call it them. Coming to the ligaments of these carpometacarpal joint of the thumb, you have a capsule attached to the margins. The capsule is very loose. That's again to allow the great degree of movements, but it is a very strong capsule, so it cannot be easily torn or damaged. So it is loosely attached. It does not tightly invests the articulating surface, loosely invests the articulating surface, but it has got a very firm and strong attachment. You have the lateral ligament from the lateral surface of the trapezium to the lateral side of the first metacarpal bone. Okay, that is actually called as the lateral ligament. Then you have the dorsal ligament, which runs obliquely from the dorsum of the trapezium to the medial side of the first metacarpal bone. Then you have the palmar ligament from the lateral side of the palmar aspect to the medial side. Okay, so one is lateral ligament from the lateral side of the trapezium, surface of the trapezium, to the lateral side of the metacarpal bone. Then you have dorsal ligament and palmar ligament, both arising from the dorsal aspect and the anterior aspect of the trapezium, and both of them going to the medial or ulnar side of the first metacarpal bone. So kindly make a note of it. The medial side has got two ligaments, somewhat firmly attached and fixed, whereas the lateral side is somewhat free. So those are the ligaments. We have seen about the lateral ligament, then we have seen the dorsal ligament and palmar ligament. Coming to the relations of the carpometacarpal joint of the thumb: anteriorly thenar muscles, medially first dorsal interossei, radial artery passing between the two heads of the dorsal interossei. Laterally you have the tendon of abductor pollicis longus, posteriorly extensor pollicis longus and brevis. Okay, so here you are able to see the various aspects. So anteriorly it will be related to the thenar muscles, flexor pollicis brevis, abductor pollicis brevis, opponens pollicis. Medially it will be related to the dorsal interossei and with the radial artery passing between them. Laterally it will be related to the abductor pollicis longus tendon, and posteriorly it will be related to the extensor pollicis longus. These are the relations of the carpometacarpal joints. Now coming to the movements. Before coming to the movements, the nerve supply, articular branch by the median nerve, and blood supply is by the radial artery. So what you come across is flexion, extension, opposition, adduction and abduction. So it has a very great degree of movement. The thumb. We all know that the thumb is present at right angles to the other digits. Not only that, if you look at the first metacarpal bone, that is the metacarpal bone of the thumb, It lies at an anterior plane as compared to the other metacarpals. It lies at an anterior plane as compared to the other metacarpals, and it is also somewhat medially rotated. Because of its medial rotation, what happens is the palmar aspect of the metacarpus has become medial and the dorsal aspect becomes lateral. Okay. So it is somewhat differently oriented as compared to the other metacarpal bones. So it is present in a more anterior plane. You can look at your own, examine your own hand as compared to the other metacarpals, and not only that, it is somewhat 90 degrees rotated. So thereby what happens is the palmar aspect is somewhat facing medially and the dorsal aspect is actually facing somewhat laterally. Now coming to the movements, as I told you, flexion and extension, abduction, adduction, then circumduction and opposition. There is also to some extent conjunct rotation. Again, no adjunct rotation. You get an associated medial and lateral rotation. Then very unique is the opposition of the thumb, the opposing movement of the thumb. Some books also refer the reverse movement of opposition is actually called as the retroposition. Okay, coming back to the resting position is actually called as the retroposition of the thumb. Okay, so the flexion and extension. If you look at the movement, the flexion and extension, it occurs in the plane parallel to the palm. So in the anatomical position of the palm, the thumb at the resting position, when you flex and extend, what happens is it occurs in line with the palm, the flexion and extension movement. And flexion is associated with medial rotation. So that's what I told you, conjunct rotation takes place, especially when the flexion is taking place. There is a medial rotation. Extension is associated with lateral rotation. Now how actually this takes place is, when you try to flex your thumb, what happens is the ligaments which is present from the trapezium to the first metacarpal, the palmar and dorsal ligament, the palmar ligament, it becomes taut during the flexion. So what happens is, when this becomes taut, due to the pull of the flexor tendons, the lateral part of the first metacarpal, which is free, rotates medially. So the long flexors, what happens is the flexors, they slightly rotate in the moment of flexion. In case of the reverse, what happens is during extension, the dorsal carpal ligament becomes taut. And naturally what happens is, due to the pull of the extensors, again the lateral part of the metacarpal is actually pulled by the extensors and it rotates laterally. So extension is always accompanied by the lateral rotation. Okay, so here you are able to see how the saddle joint, the diagram, how actually the thumb slides over the trapezium board, the ellipse, the saddle variety or the cellar variety. Okay, so flexion associated with medial rotation, that is why the lateral part is kept free, whereas the medial part of the metacarpal is anchored with the help of two ligaments, both on the palmar surface and the dorsal surface. So flexion is brought about mainly by flexor pollicis brevis and opponens pollicis. At a later stage, when more power is needed, then flexor pollicis longus come into action. Extension is mainly brought about by abductor pollicis longus, extensor pollicis longus and brevis. Abductor pollicis longus also bring about adduction of the thumb. Yes, because that is why the abductor pollicis longus tendon is obliquely oriented. It is not straight. Since it is obliquely oriented, so when there is a pull by the tendon, it also brings about the adduction of the thumb. So apart from that, extension is brought about by extensor pollicis longus and extensor pollicis brevis along with the abductor pollicis. So abduction and adduction, as I told you, it as at right angles to the palm and occurs around the transverse axis. Okay, so that is about the abduction and adduction. So muscles which bring about the abduction is abductor pollicis longus and brevis, and adductor pollicis brings about the adduction, whereas the palmar interossei brings about the adduction not at the carpometacarpal but at more distal level. So circumduction is a combination of flexion, abduction, extension and adduction. Okay, so it is brought about by the flexion. Actually, circumduction is a combination of these three movements. The next unique movement of the thumb is the opposition movement. So at the carpometacarpal joint, so it is a combination of abduction, flexion and medial rotation, and mainly abduction can be performed, opposition can be performed in an abducted thumb. So it is flexion and medial rotation in an abducted thumb. So the thumb is mainly semi-flexed and is in contact with the other fingers. So opposition movement is by flexion and medial rotation. So again, when more pressure is needed, flexor pollicis longus come into action. This is mainly for grasping any object. The muscles which bring about is initially abductor pollicis longus and brevis comes into action. There is no opposition in an adducted thumb. You try to keep your thumb adducted and you try to oppose, it is not possible. Only in an abducted thumb you can bring the opposition movement. So that is why this is mainly brought about or initiated by the abductor pollicis longus and brevis. Then it is maintained by the opponent's pollicis. And at the later stage, flexor pollicis brevis comes into action. Then if you want more power for grasping, then naturally what happens is the flexor pollicis longus also comes into action at a later stage. Okay, so opposition is brought about by abductor pollicis longus and brevis, maintained by opponent's pollicis, and then flexor pollicis brevis, and finally flexor pollicis longus increases along with abductor pollicis longus. So that is about the movements which is produced at the carpometacarpal joint of the thumb. Coming to the applied aspects, Bennett fracture is mainly due to the first metacarpal, base of first metacarpal fracture. It is actually called as the Bennett's fracture. More common, and subluxation of the metacarpophalangeal joint takes place. We have one more fracture which is also called as the Rolando fracture. So fracture mainly of the scaphoid bone also takes place in case of the Rolando fracture. So these are some of the two applied aspects. So in this we have seen mainly about the wrist joint and the first carpometacarpal joint. So thank you very much. We will meet again in one more lecture very shortly.